Hi, my name is Greg Ellis. I'm a physical therapist and strength and conditioning specialist. I work out at Rehab to Perform in Mount Airy, Maryland. And today I'm going to talk about sports-related concussion in youth athletes. Here are the objectives for today. I want to define concussion and some of the symptoms, provide some resources for coaches and parents to learn more about concussion, provide insight into clinical evaluation processes and treatment techniques, and identify goals of acute concussion management. And then at the end, I'll kind of provide some insight into the return to play and learn protocols, and then discuss the current research regarding concussion prevention, as well as some protection. I'll start here with some concussion myths. I'm going to touch a lot of these throughout my slideshow, but I want to highlight a few different ones here. In fact, right here it says concussions can only occur when a loss of consciousness happens. We know that about 90% of concussions do not involve the loss of consciousness. Another one I'd like to talk about here is you must be placed in a dark room to recover from a concussion. Along with this is a lot of times people say you should not let somebody go to sleep following a concussion. Now we know with evidence-based treatment that there are actually some active techniques that we can go about ensuring that these players are recovering appropriately. And then the last one I'd like to talk about before getting into everything else is having one concussion places you at risk for future concussions. That is a myth. Proper clinical management is the best form of prevention. Recovery from one concussion does not put an athlete at risk for another. However, if you're going down the route of poor concussion management, you will be at risk for further prolonged symptoms from a concussion. So what is a concussion? It's a subgroup of mild traumatic brain injury that results from an impact of the head, neck, face, or body, resulting in an impulse through the head. We know that there has to be a rotational and a linear component of this force, often seen with a glancing blow to the head or something of that nature. What makes concussions really hard to diagnose on the spot is that these symptoms will evolve over minutes to hours following impact, and they'll resolve spontaneously over the recovery period. These symptoms also largely represent more of a functional disturbance rather than a structural injury. This is why MRI, fMRI, those types of things are not necessarily recommended when you're looking at evaluating concussion. We know that as far as prevalence and incidence, concussions are on the rise. I think that reflects more of a knowledge about concussions that occurred in the early thousands. In this study highlighted here in this slide, they actually, in the school system, they added many more athletic trainers to field sites that actually assisted in diagnosis and recognition of these symptoms. So that's probably what we're seeing rather than an actual increase in the incidence and prevalence, just better diagnostics. So how do we recognize concussion symptoms? Well, they kind of fall into four different buckets of physical, cognitive, emotional, and sleep disturbance. These vary from headaches, disturbances in vision, fatigue or drowsiness, light and noise sensitivity, and some balance disturbances. Early on, you might even see some nausea and vomiting. Cognitively, you'll see slow memory processes, an inability to really remember new information, as well as difficulty concentrating, things of that nature. Emotionally, you're going to see some irritability, sadness, just feeling down and not feeling right, and maybe some onset of nervousness and anxiety. And then we also know concussions affect sleep, whether that's sleeping more than usual or having trouble falling asleep or staying asleep. So those are your four buckets of symptoms there. How are concussions diagnosed? Well, they're going to be diagnosed mainly on field assessments, usually completed by an athletic trainer, team physician, or another healthcare provider that's on site and trained to handle those situations. They're going to be made by identifying those common signs and symptoms I just went through in an athlete that just took an impact to the head, neck, face, body, etc. And there's also a multitude of sideline concussion screening tools that are used to establish symptom baseline, vital signs, and all of those symptoms as well to help diagnose. So there's going to be following an impact, you're going to have those signs that you can observe as an observer. You're going to see the player that looks dazed. He's confused about his assignment. He's forgetting what led up to the event or directly afterwards. Occasionally you'll see they don't know the score of the game or maybe what team they're playing. You can see a loss of consciousness. We know that's not always the case, but it can happen for even briefly. And we'll see mood, personality changes in an athlete. That maybe is out of the norm for that athlete. But what is the athlete going to say to you after this? They might describe a pressure in their head. They might actually come up to you and say, "Coach, I'm feeling a little bit unsteady, some difficulty seeing, just feeling groggy, Coach," or they just don't feel right. So what do we do if there's not a healthcare professional on site? We know that since the early thousands, we have started to put more healthcare professionals in these places to make these diagnoses, but we can't always be there if that's practice or something of that nature. So what happens there? You see an athlete take a hit to the head, that you see some of those symptoms. The responsibility is going to fall on the coaches, the parents, the players, or sometimes even the officials. And if you're really worried about it, if you have any doubt, you should sit them out. And that's from the CDC with their Heads Up program that I'll get to here in a few minutes, or right now. So this is a wonderful resource for coaches, players, even parents. If you go to the website here, you can get Concussion 101, so to speak. They have handouts for coaches, even for parents, so they can just get the baselines of what they should look out for, whether that's going into a season where it's a possibility or following an injury, just so you have an idea how can you best help your child following one of these injuries. Another one that I came across that I found to be excellent was University of Pittsburgh Medical Centers. They rethink concussions.com. Again, they have that Concussion 101 type course, and that's an actual concussion treatment center. So they're a little bit more geared to this concussion has occurred. What are the next steps? So the clinical side of things, following the injury, these athletes are going to be evaluated by a physician, and they're going to undergo a comprehensive clinical exam in which they'll maybe rule out some more serious medical conditions if needed, whether that's cervical spine instability, a fracture of the head, neck, or face, something of that nature. They'll rule out maybe a subdural hematoma that might require immediate medical interaction or intervention. But at these meetings, they're going to be establishing a symptom baseline. There'll be a full neurological screen, looking at balance, their vision, and then they'll also make any kind of recommendations for further referrals out, which I'll get to here in a bit. So further, that physician will determine if an athlete is appropriate for exercise stress testing. A common theme for concussion is exercise intolerance due to some autonomic nervous system dysfunction. This exercise stress test is usually in the form of a bike or treadmill test that's graded in nature. We know with that autonomic nervous system dysfunction, symptoms of their concussion, headache, dizziness, those types of things will occur very early on before they're actually being metabolically stressed, so to speak. So in those that are demonstrating exercise intolerance in the onset of symptoms related to their concussion, we're actually going to see some different subtypes of things that might need to be referred out for treatment. That would be your post-concussive syndrome, that autonomic nervous system dysfunction, and then you could also see some vestibular issues that might require vision therapy or vestibular imbalance training. And then you also see cervicogenic post-traumatic disorder, which is what you might refer out to physical therapy to address the musculoskeletal system. That can often refer into the head and give you some similar post-concussive symptoms. This is a nice flow sheet that kind of sums up everything I was just talking about here. Essentially, that secondary assessment, that exercise test will occur, and they're going to be put into kind of 4 different buckets here. If they pass the exercise stress test with exertion being the only thing that limits them, they'll go ahead and enter the return to play and return to learn processes. That would be considered physiological recovery. However, if you have the exercise intolerance, those are the three buckets to the right that I kind of just hit on. You'll notice that regardless, they're going to recommend some submaximal aerobic exercise that's kind of defined what their symptoms occurred at during that exercise stress test. It gives you a target heart rate to stay below for something like walking and biking. So, acute concussion management, bypassing that kind of evaluative process, what do we want to do? Well, acutely, you want to provide a environment for healing and recovery. So the brain is thought to be at a little bit more vulnerable to further injury that could be more severe and really complicate recovery in that acute timeline. We also know that 80 to 90% of concussions will resolve in about 2 weeks, regardless of whether they receive formal intervention. But there's a subgroup of that 10% that can really prolong their recovery to 3 to 4 weeks, and those are the ones you're going to see more cognitive issues in the return to learn process, as well as a delayed return to sport. One key finding here down at that bottom, that's that fourth point, is that while only 10% took greater than a week to recover, they still found that the neurophysiological recovery, or the cognitive issues, tended to lag behind the physical symptoms by about 2 to 3 days. So your athlete starts feeling good, but you still might see some deficits in the classroom at that time. So I kind of already hit on the goals here of trying to provide that environment for recovery, initiating some submaximal symptom-limited activities of daily living and exercise to help decrease that autonomic dysfunction. So following injury, they're going to be recommended 24 to 48 hours of physical and cognitive rest. Previously, this was typically the first line of treatment. They often extended this longer. However, now we know that it's better to get a moderate amount of activity in after that first 24 to 48 hours, where they can gradually resume those symptom-limiting activities of daily living that are not physically or cognitively stressing. So what you might consider at this point is to decrease the use of cell phones, no schoolwork, no television, no video games, those types of things that can be cognitively stimulating. They might not be that stressful, but they can stimulate the brain and kind of delay recovery a bit in this initial acute period. Based on their performance in the exercise stress test, you will initiate exercise under that target heart rate. And then once they pass that test, that exercise stress test, and they receive medical clearance, they can eventually, or they can enter that gradual return to play and learn process. So regarding returning to play and learning, the largest predictors of delayed recovery will be the intensity of symptoms at initial evaluation and what that overall cognitive activity level is in that acute phase. As I previously mentioned, the cognitive deficits tend to lag behind the physical symptoms. But we know in regards to return to learn, concussions affect memory, processing speed, and concentration, all of which are needed in the academic setting. So that's going to be why we're going to have that graded return to learn process. So I'll start with return to play only because you tend to see that physical side of things calm down a bit before the cognitive, and that aerobic exercise can actually assist in recovery. But this study right here looked at a combination of that exercise stress testing as well as a gradual return to play protocol that we know about. Once they passed the test, they entered the Zurich guidelines for return to play. They found that 100% that proceeded through the guidelines without symptom exacerbation, they also successfully returned to sport. So that's really, really good. However, in this subgroup here, you saw when they followed up with them a couple months later that about 40% of the kids that returned to sports successfully, meaning that they went through without symptom exacerbation, they still had school-related issues. So maybe they entered the school and returned to learn a little bit too aggressively, and that wasn't quite addressed as well. Here are those Zurich return to play guidelines that I discussed there. They're fairly straightforward. There's 6 steps here. It is recommended that 24 hours in each of these steps, so about a week to enter return to play fully following passing of that exercise stress test. You start by no activity, that's that initial cognitive rest phase. Then you go into the light aerobic exercise based on the stress testing. They're able to tolerate that. You add sport-specific running or skating drills, think your agility type things. And then if they can tolerate that, you add a ball in, because that is a little bit more cognitively stressing, requires a little bit higher intensity, and you're adding more sport-specific movement. Following that, they can enter the full contact practice and then eventually game time. Now we're going to go a bit more into return to learn. So in this study here at the top, those students that entered back into school with still having concussive symptoms, they tended to have more school-related problems compared to those that were symptom recovered. So what's the goal here? Well, you want to gradually introduce cognitive stressors that are not going to be detracting from that recovery. So encourage that moderate physical and cognitive activity, because moderate levels of exertion are associated with better symptom and testing performance, as well as their prognosis going forward. That would be in contrast to adding too much too soon, or just taking total physical cognitive rest a little too far. So I mentioned a little bit earlier, there's a really small subgroup of those with persistent post-concussive syndrome. These are the athletes that take 3 to 4 weeks plus to recover. Those are the ones that you really have to be careful and think about with the return to learn process to avoid those long-term school-related issues. This is where you might need to get with your school counselor to discuss a possible 504 plan, which is part of the Americans with Disability Act. And with that plan, all you need is medical clearance by a physician that says, yes, we do need these accommodations. In a very even smaller subgroup, you may need to go the route of an individualized educational program, or IEP, although that's not always necessary. That's a little bit further, more stringent. But what are some useful recommendations for the return to school process? How do we encourage moderate activity without exacerbating symptoms? As soon as they are able to tolerate, they should, the athlete, enter back into school, even if it's for 45 minutes. If at 45 minutes they start to have their concussive symptoms, they should be taken out of school and allowed to physically and cognitively rest until they're symptom-free. Then you kind of bring them back in the next day at about 80%, some say, and just kind of go in that interval type process until they're able to tolerate a full day of school. We also want to give them more time for going through notes, pre-printed class notes, additional time for assignments. We want to excuse non-essential work, so don't double up on their workload. Additional help and tutoring may be needed, so that's where you need to advocate for your student, for your child, to work with school counselors and be sure that they are getting the accommodations they need. And you don't want to test until they're able to tolerate a full day of school and then allow untimed testing. And now we're going to get kind of the end of this talk in the concussion protection and prevention. I'm going to talk a little bit about the research and then at the end kind of come up with some recommendations. But at this time, there's limited to no evidence that current helmet designs, face masks, or mouth guards reduce concussion risk. However, there's great evidence that they prevent other sport injury, eye injury, face, mouth, those types of things. So they should be encouraged to use, but they don't reduce concussion risk. At this time, current testing standards for that protective equipment, think your helmets, they don't include that rotational acceleration and velocity component that I discussed is the mechanism of injury for concussion. So you can't effectively gauge the reduction in concussion risk. You're not effectively creating that mechanism of injury. Research also shows that concussion education improves knowledge about concussions. That's an excellent thing. The more awareness we have, hopefully the better our outcomes are. However, we need more research to evaluate the ability of these programs to change the attitudes and beliefs about concussion and actually improve youth athlete concussion reporting, which is a big challenge. A lot of these kids are not willing to report concussion for a variety of reasons, be that they didn't want to let their team down, or they didn't think it was that serious. So that's kind of where we need to really go with our education. We've also looked at limiting contact in youth football practices. They found that it results in a less frequency of head-to-head contact, but it doesn't show a decrease in sports-related concussion. I think this can be explained by the fact that we also know that more concussions occur in game time compared to practice because the intensity level is higher. What about tackle target training? Lowering that target zone, that's a big thing that's often discussed. They even, in this study, taught kids how to tackle without pads or helmets to try to take that element out of it. And still, there was no effective way in reducing sports-related concussion, this study said. So to kind of sum it all up, the findings surrounding sports-related concussion prevention and protection remains inconclusive due to conflicting evidence, lack of rigorous study design, and inherent study biases. So what needs to change? We need to continue to challenge and change the attitudes and beliefs regarding injury as a whole in sport, not the need to push through an injury, but the ability to recognize, let the medical staff do their job, and they'll tell me if this is an injury I can play through and address later, or we need to get better care. We need to also understand the significant sociocultural and psychological factors regarding injury in sport. We need to continue educating individuals on concussion, players, coaches, parents, all of those. And we need more rigorous and stringent, in-depth testing, regulation, and research studies so that we can actually go about making appropriate recommendations to reduce risk. And that'll wrap it up for me. If anybody has any questions at this time, I'd be happy to answer them.